Yes, now we're live. Let's wait just a few seconds, Nazim, because some people are coming in, and yeah. All right, connection is good. Connection. Now I can see you better also. So yeah. Yes. All right. So let's start, Nazim. We have now almost 150 people starting to watch us. I'm sure that more people are coming. And first, I would like to thank you a lot for your time, Nazim. I know you're very busy, and for me, it's an honor and a great pleasure to talk to you because you know that I consider you my father in structural rhinoplasty. When I just finished my training, you were uh, one of the guys that who took my hands and you taught me uh, all the concepts that I took for my life, and I'm sure that was life changing for me. And you know that, and I would like to thank you so much. I'm very honored to speak to you today.
Thank you, Fernando. Can you hear me clearly, by the way?
Yes, yes, yeah.
Okay, thank you for inviting me to this live talk. It's a pleasure for me and honor. And uh, you came to Istanbul maybe 10 years ago or 11 years ago. How many times you came to Istanbul to visit me?
Oh, 5 times.
5 times. Okay, you are one of my best fellows who is really passionate about rhinoplasty, and really that makes me very happy because to teach somebody, and if my fellows are uh, advanced in rhinoplasty, if they are passionate about rhinoplasty, that really makes me very happy because in this world we have to share what we know. I think this is the most important thing, and transmit the knowledge to the next generation. And I know that you will be much better than us. You are already very good rhinoplasty surgeon, and I'm proud of you. But the next generation, of course, will be better than us, and this is the evolution of the human being. So now there are new techniques came up, and I'm very excited about that, and we're gonna talk about that. The rhinoplasty evolved a lot in the recent 20 years. It's amazing, and the rhinoplasty when I started to do, I when I remember the cases I operated, how I was operated on those years, and we were considering that we successful surgery. We were butchering all those noses. Now when I go back and think about the techniques we were using, of course, you have started to do rhinoplasty in a much higher level, and this is your advantage, and you will be much successful. You will, in terms of results, and you will be much better surgeons. So
Oh, thank you. But it's always good to have mentors in who we can like focus the way you act with patients, the way you do your surgeries, and we know when we see people like you have mentors like you, we know um, our focus and we know what we have to achieve to become successful like you. So thank you so much, Nazim. I'm just
so
gonna
I want
speak
to
very
I want to give you one message. Rhinoplasty is one of the most sophisticated, more complicated surgery on human body. And I can say among the all aesthetic procedures, it is the most fun surgery for me because during rhinoplasty, not only my hands are working, my brain is working. And it's not
Yeah,
boring. Every case is another challenge. And that's why I love this surgery. That's why
yeah,
particularly secondary surgeries are even more challenging. And I enjoy doing those challenge cases. So,
oh,
and it's a lifetime learning surgery, and you have to improve your knowledge, you have to improve your results, and you have to update your knowledge, and you have to take lessons from your mistakes. This is the most important. You have to be self criticizing to improve in this field. This is very important. If you say that I do always the right thing and this is the right thing, though, no, you cannot advance much. You have to criticize yourself. You have to judge your results and always think about how I can do a better rhinoplasty. What was the mistake in this case? How I could achieve a better result, even though the patients are happy with your result. And try to try to search the best. Maybe there is no perfect result, completely perfect result we achieve, but we can get as good as possible, and we should for improvement our results we have to criticize ourselves and follow the patients and see the results and self-judgment, self-criticization, criticization of ourselves. This is the most important.
oh yeah. I Nazim, we're gonna go. This is very nice what we're talking. I'm just interrupt very briefly here just to thank our people from Brazil, so Latin America. Okay, and we have more than 300 people, almost 350 people now, and
Okay.
very briefly, and then we come back to this subject. All right. Uh, então, obrigado aí a todos os amigos do Brasil. Eu sei que o Dr. Nazim é muito querido aqui no Brasil, todos vocês gostam muito, ele já veio diversas vezes no Brasil, então muito obrigado aí a todos que estão junto hoje, para a gente aprender um pouco mais aqui das filosofias e saber um pouco mais da história dele também. Y gracias a todos amigos de Latinoamérica, una vez más, todos juntos, mucha gente de México, Argentina y todos los otros países también, Colombia, Venezuela, y hoy estamos con el doctor Nazim Çerkes para hablar un poco de la rinoplastia secundaria y la filosofía de él en la cirugía de la nariz. Okay, muchas gracias. So Nazim, coming back to what we're talking. I visited you more than 10 years ago, and a brief history here. On that time, I was in the United States doing my fellowships, and I was with Dr. Renato Salks, which is your brother, right?
Yeah.
And I just told him, oh, I'm feeling comfortable in facial surgery, but I want to learn more about rhinoplasty. And I remember as if it was yesterday that he told me, "Do you want to go for a good surgeon or the best surgeon?" And I answered, "Of course, the best surgeon." And he said, "You have to go to Turkey." And on that time, I didn't know anything about Turkey or Istanbul, but I went to Istanbul for the first time as your fellow, and for me it was completely life changing. And thank you so much for that. Okay, and I see that what you were talking about, your evolution, because I visit you 5 times, and from the first time and for the last time that was this year, I see clearly your evolution, especially in secondary difficult cases, because it seems that you're always thinking on how you can get better. And in one certain time, when I was visiting you, you told me, if you like rhinoplasty, you will see that it's kind of passion to like rhinoplasty, but it's tough because you have to deal with sometimes with bad results keep evolving, right?
Yes, yes. You have to dedicate yourself for this surgery, and you have to focus on this surgery. And maybe you noticed my evolution, even though you know I'm right now 60 years old. I still try to improve myself in terms of my techniques, in terms of my results. Otherwise, it's like a aeroplane. It's flying. If you stop, if you reduce your speed, you fell down. So in rhinoplasty, is you have to do the same. You always have to improve your result. On the other hand, uh, today the patients are seeking perfect results. One of the disadvantage for us, uh, in one way, it's advantage for advertising, but disadvantage is social media, because the patients are seeing always perfect results on social media, and they cannot tolerate anymore, even very minor deformities, minor asymmetries. And the patient of rhinoplasty became much more difficult and to handle, and much more demanding. And this is bad for the beginners, because we all did mistakes, and we will all do mistakes, still will do mistakes. So but when the patients have seen very promising perfect results on social media, that they may you know create you a lot of problem post-operatively, and it is sometimes very difficult to tolerate uh, for me, the demands of the patients, complaints of the patients. So that's why I'm very, very obsessive in selecting the patients. If I feel uh, any if I feel that the patient is very obsessive and expecting as perfect result, I better not to operate those cases, which I do.
Okay, that's great. And for we have more than 400 people now, and just to tell you guys that at the end of our talk, we're gonna answer questions and also discuss some difficult cases. All right, so everybody stay there. And okay, Nazim, and tell us a little bit more. Last time I was, if you said that this patient selection is so important, right? Because you said that sometimes we really have to operate people who understand our limits, right?
Yeah, yeah, that's what we would like. And BDD rate in rhinoplasty operation is pretty high. So, but we we don't consider that issue too much, I believe, as rhinoplasty surgeons. So even though you do a good result, a good surgery, it's not easy to satisfy those patients, and it is really scary for me to operate a wrong patient. So the difficulty of the surgery doesn't matter for me. I love to do difficult surgeries, but difficulty of the personality of the patient is the critical thing in decision of the surgery. That's why I spent a lot of time, in many cases, two consultations, sometimes three consultations before I decide to do the surgery. Why I am so obsessive? Because I cannot tolerate anymore the complaints of the patient, and I don't want to face with a bad patient or unhappy patient, and who's gonna come to my office and complain, and that happened in the past. So I'm very cautious in selecting the patients because of that reason. One of the very useful tool in selecting the patients is the imaging programs. That really helps me because on the screen, on the computer screen, I do a simulation of the surgery. Uh, if the patient doesn't like that simulation, that means that 100%, almost 100%, the patient will not be happy after the surgery. This a very important warning sign for me. And to discuss with the patient what she or he like, and understanding the expectations of the patient is very important, and the software programs are very useful. By the way, I'm using a pretty simple software, not 3D, 2D, but it is enough, more than enough. And the most important thing here, not to show over realistic results. I can do on the software program very beautiful nose, but I never do that. Instead, I do very decent result. I don't want to show, even though I can do the better result, I don't want to show that result to the patient. And this is important because otherwise the uh, patient's expectation will be too high, and they will not be satisfied.
Great, great. Yeah, I've been using also some very simple apps on my iPad, and I can do some simulation on the consultation, and I noticed exactly what you said. Sometimes you can uh, understand what they're expecting, right? And once you understand that, you can know that if you can achieve or not, and that helps us a lot to select the patients. Yeah, that's so great tip.
I think in patient selection, by the way, one of the difficulty is selecting the right secondary cases. Because if a patient comes to you with a terrible secondary nose or tertiary nose with terrible deformity, we think that we have to help to that patient. But behind that, there is a personality problem, and there is BDD. Perhaps it's understanding that that problem is more difficult in secondary cases. Now I'm more cautious about in selecting the secondary cases as well, because I
Okay.
did mistakes in the past in selecting the wrong patients in secondary rhinoplasty group.
Okay. And Nazim, I know that you received fellows from all over the world for many years. I'm proud of being maybe the first or one of the first Brazilian fellows that you received. And I had the experience, recently experienced in my institute here to teach a fellow also, and I receive a lot of people from Brazil and some people from other countries to visit us. And for me, it's something really amazing how we can help other people also to grow, because this is a so challenging surgery. And every time we receive, at least for me, when I receive a visitor, we teach them, but also we grow a lot because they force us to explain in a better way, understand what we're doing, and this way everybody grows. So in your case, that for many years you're doing that, okay?
Yeah,
What is the main reason for you? What makes you very happy to have people from all over the world coming to you and you teach them?
yeah. I think you know. teaching somebody is even more important than earning money for me, because I really enjoy doing that. I go several meetings, I lecture every year. I used to lecture, not right now. All the meetings this year are cancelled, as you know. I
Yeah.
supposed to go 24 meetings in 2020, but I
Wow.
was able to go only two or three of them in the January and February, and then we stopped traveling. So I really enjoy teaching, because uh, if you help somebody to improve themselves in a special subject, that's really rewarding for me, because I can see the eyes of the happy eyes of my fellows, and also when I see the improvement of my fellows, like yourself. I have many fellows in Brazil. I had 50 so far, only from Brazil. Maybe
Yeah.
over 300, 400 from all over the world, and that is the biggest happiness. And this is the this is this is invaluable for me. I cannot compare it with the money, and I'm not doing this surgery for the money. Of course, we all earn money from our profession, but this is, to me, this is more important than everything. To teach
Wow. That's,
somebody and to see improvement of your fellows and students.
yeah.
So because
Great.
I saw a lot of respect from my fellows. Whichever country, whatever country I go, I have some fellows who visited me, and they host me and they respect me. This is very nice. Then I love to do that.
Yeah, I remember when I was in my residency, I trained with Professor Pitangi, and he used to teach a lot. And there was some other guys on his same age, but they used to close the door of the operating room. They didn't teach anybody. So if you compare over time, people were very grateful and thankful for people
Yeah,
who teach us, right? And
yeah,
the
they
other,
they are very
yeah,
very
if people don't.
grateful and thankful. Also, people thinks that if I teach somebody, they will learn and they will compete with me. That's not correct. Actually, with teaching, I had more patience. I can
Yeah,
tell you. I can tell that, because my fellows now are referring patients to me, very difficult surgeries to me. Or let's say I have a fellow in Germany, and one of his friends asked that there is a patient in Turkey, living in Turkey, whom you recommend, and he will give my name, and that patient is gonna come to me. These are the benefits of teaching, in terms
yeah,
of business. I can
yes,
say that teaching, improved my business. On the, I didn't,
great,
had any competitor, and
great,
it's good to compete. On the other hand, because that pushes you to advance, to improve. When you look at me in Istanbul, there are maybe 20, 30 excellent nose surgeons, and
yeah,
that competition improved the quality of the rhinoplasty results in Istanbul. That's why Istanbul is called the capital of rhinoplasty.
yeah, that's true. And you're part of the history of this stage that Istanbul has nowadays, right? People call Istanbul the capital of rhinoplasty because there are so many good rhinoplasty surgeons, so many patients. And what do you think is the main reason for that? Because I know that you were one of the first guys to go to all the meetings around the world, spreading the how good was Turkish rhinoplasty. How do you think is that?
Well, you know, in Turkey, the medicine is very advanced. When I compare the general level, economic level, or education level of the country, comparing with that, and the medicine is much better than the general level of the country. Uh, why this happened? The first thing is that Turkey is coming from the root of an empireship. That's the Ottoman Empire, and then we had a great leader who gave importance, focused on the education, who is Kemal Atatürk, the founder of the modern Turkey. So the education and science was his privilege, and gave importance and invested on the universities, and all the the what I say, all the brilliant students wanted to become doctor, and then that improved the quality of the universities and the scientific level of the universities. I'm talking about 50 years ago, or during the time of the Second World War, and the Turkish universities became pretty good in the scientific level. Then on the next generation, and even the better doctors were raised, and plastic surgery is one of the most popular branch recently, and the best of the best students became plastic surgeon, and that's one of the reasons. The second thing, that because of that, not only in plastic surgery, Turkey is very advanced. I can say that even better than many European countries in the cardiovascular surgery, in orthopedic surgery. We have great surgeons in general surgery, whatever. So why Istanbul became capital of rhinoplasty? Because this is the most common surgery. In Turkey, for example, we don't have very great facelift surgeons because it's not a common surgery. But rhinoplasty, every plastic surgeon does a lot. And rhinoplasty is such a surgery that without performing that operation, you cannot improve your skills and you cannot get experience, even though
Yeah.
you have a good knowledge about that, but you have to do that surgery, and you have to do pretty often. So I used to do like 250 surgeries in a year. So it's not a very huge number, but I cannot do more than two cases every day. If I do secondary, I schedule only one case because it takes 4 or 5 hours. And if you don't do much than 50 cases a year, you really don't improve yourself. You cannot advance on that. And this is the main reason that Turkey became the advanced in rhinoplasty. Both things: good doctors and the number of cases, the
Oh,
opportunity
great.
to do rhinoplasty.
Great. And Nazim, so we have almost 500 people here. I know that we're people want to know about rhinoplasty. So let's go to rhinoplasty. Tell us a little bit about your thoughts on preservation and how it's been used to combine with structural rhinoplasty. You were a very you're very strong structural rhinoplasty surgeon, right? And how do you see this preservation thing, and how can you deal with some cases? In which cases do you think you could combine preservation?
All right. Okay. Very, very good topic to discuss. First, let me start with my journey. I think I performed my first rhinoplasty in 1987, 88 when I was resident. And we were doing all closed rhinoplasty on those years. And I became the plastic surgeon specialist in 1990. Then I went to United States for 1 year for fellowship to University of Alabama. I met Renato Sals, Jim Grotting, Luis Vasconez over there. I learned a lot from them. And, I observed some ENT surgeons on those years. They were the even delivery technique was not I haven't seen delivery technique in Turkey, but there was a guy who was doing a delivery technique that was amazing for me. And I believe that I could do everything in closed rhinoplasty, and I did 10 years closed rhinoplasty between 1990 and 2000, and then the open rhinoplasty became popular in 1990s, but I was a kind of skeptical about the open technique. Then, but I was doing open rhinoplasty in secondary cases, because on those years we were not doing in the closed rhinoplasty the reconstructive methods. For example, we were routinely resecting the upper lateral cartilage. And we were resecting a lot from lateral crura and so on. And in many cases, I had asymmetries with the closed rhinoplasty, or internal nasal valve problems, functional problems, dorsal asymmetries. And then I said that I have to go to open rhinoplasty. And in 2 years, I did 50% open, 50% closed. Open rhinoplasty gave me a lot of advantage in terms of visibility of the operating field. And then I started to do the spreader flaps, and that changed my results and life a lot. And after doing the spreader flaps, my results became even much better. And then till that time, since 2002, I've been doing open rhinoplasty. And then I'm happy with my results, and I can say, really frankly, in primaries, my revision rate is between 1 to 2%. And and my revisions are usually due to under resection or under rotation, which are easier to fix comparing to over resections and the over rotation, of course. So then in the recent years that if someone pioneered to repopularize the preservation rhinoplasty, and I have been observing the evolution of the preservation rhinoplasty very carefully. So what is my philosophy in rhinoplasty? What I learned in 30 years? It is always better, the principles should be, let's say, the principles must be to perform the surgery with minimal dissection and minimal grafting. Because every additional dissection, unnecessary dissection, dissections should be large enough to allow the execute the maneuvers. Otherwise, why do you do excessive dissection? That's why I like the ligament preservation concept a lot, and I will talk about later. And the minimal grafting, we used to put a lot of grafting, and I saw a lot of problems with the grafting, even with this columellar strand, which is the most commonly used graft. So the principle must be to complete the surgery with minimal grafting and minimal dissection. That's my principle. So in the, I am a conservative guy, and first of all, I want to see the results, outcomes of the new techniques. If when let's say, in my practice, um, I bought a lot of new devices, the lasers and so on. But I didn't buy it, as soon as it's launched on the market, because I have always questions. If this is working, is there any side effect, any problems with that? Because I have to make sure to start to do a technique or to use a new device. This is my personality. I do not jump on a new technique and or a new device and new method. First I observe carefully if I believe that this may work, and in that case I start doing that. This is the one of the reason that I didn't want to go on to preservation rhinoplasty immediately. By the way, I did a few cases, not too many, and my still I have question. What are the problems related to preservation rhinoplasty? Uh, I think every surgery needs a learning period. I can say that in 20 years, uh, I could improve myself in the structure rhinoplasty, open structure rhinoplasty. It took many years, and still learning about that. And I'm right now 60 years old, and I'm not going to operate another 20 years old. So maybe if I start to do preservation rhinoplasty now, I will be a good surgeon, good preservation rhinoplasty surgeon when I am 70 or 75. But I will have many problems, many secondaries. I believe so, and that I cannot tolerate. On the other hand, when you get aged, it's hard to tolerate an unhappy patient. My patient group is different than many young surgeons of the patient group. To me, the most obsessive patients are coming. They are seeking the excellent results, and also I can say that openly I charge more than all the others. In that case, if the patient is paying high, they do not they don't want to have any deformity, and they expect uh, almost perfect results. So this is another reason. The third reason is that why I am doing the structure rhinoplasty. Structure rhinoplasty, as I told you, my results are satisfactory to me, to my patients as well. On the dorsum, I don't see any irregularities with doing spreader flaps and the keystone reconstruction techniques, which I presented, in many meetings. I am happy with the results, with my dorsum results, and I believe that at the moment, the problems related to preservation rhinoplasty have not been reported yet, or have not been reported sufficiently. I want to see the complications with the preservation rhinoplasty. I don't want to blame the technique, blame the surgeons. But I am one of the, secondary rhinoplasty surgeon. More than 50% of my cases are secondaries, and I am operating the the complications of the preservation rhinoplasty. On the other hand, to predict the dorsal height with the preservation rhinoplasty, particularly in, push down and let down technique, it is not so easy, I believe, because on the structural rhinoplasty, when we do the reduction from the bony dorsum and cartilaginous dorsum, we can see the dorsal height on the table. Even with the structural rhinoplasty, with the healing, we can see some variation after the surgery. But how much we gonna remove from the base of the bones when we do the let down technique? It is very hard to predict in the beginning. Maybe it's gonna I'm gonna learn when I do it pretty often in a few years how much bone I'm gonna resect from each patient. This is in the beginning difficult to me. I do how I do when I do the preservation rhinoplasty. I only do the cartilaginous dorsum preservation. I never do the cuddle maneuver, and that is to me is very very unpredictable. And I mean, it's not only unpredictable, scary, because the bony and cartilaginous skeleton stability is the most important to me, according to my principle. Then these are the main reasons why I don't do preservation rhinoplasty. When I do preservation rhinoplasty, in which cases I do, the cases with the symmetric cartilaginous dorsum, pretty fairly narrow cartilaginous dorsum, and in those cases, I only resect from do high strip resection and the cartilaginous dorsum push down, and then I do the bony resection and the osteotomies with the classical way.
That's great. That's great to hear that from you that are so experienced with structural rhinoplasty. And I remember also that since more than 10 years ago, when I learned from you the concepts of structural rhinoplasty, I always realized that you did a conservative structural rhinoplasty, okay? Because when most of the people, when they learn during their training, they learn like a prescription, or oh, you have 5 grafts, you use 5 grafts in every case. So I learned from you that it was not that way, that you could use the cartilage of the own patient to do some flaps, and you don't have to use a lot of grafts. And during all these years, I was trying to reproduce some of your concepts of bring preservative in some way, even in structural rhinoplasties. And I think
Well,
that
yeah.
influenced me also on the preservation, because I thought I was always thinking, how could I be less invasive? And maybe that's why I also wanted to learn a little bit more about preservation. But I agree with you, there are some things that we still have to check in the future about learning curve and complications about a new technique.
And I will say one thing. Recently, what I learned from the preservation guys, this is the evolution of the rhinoplasty. I learned from Barish that, and Göksel, they are preserving the scroll ligaments, for example. I think
Yeah.
this is a brilliant idea. And, if possible, if I don't need to redrape the skin too much, I preserve the scroll ligament. And in some cases, not in all cases, I resuture the Pitangui ligament as well. I think that preservation, ligament preservation is excellent. We have to preserve as much as we can. On the other hand, but this is the criticize of the preservation. When you do the total deglobing, we disrupt the piriform ligament, for example. Every surgeon, all of us, let's say, are talking about the advantages of the technique. Nobody talks about the downsides of the technique we use and the complications of the techniques we use. But I believe in years we will see the advantage or predictability of the new this new technique. I
Yeah.
believe that will be this is a big contribution, big evolution in rhinoplasty. I believe in a few years, in 10 years, it will be a big change in rhinoplasty with the preservation technique. Maybe not all the techniques they use at preservation surgeons use at the moment, and there will be some changes, and we will select the good maneuvers, pick the good maneuvers from those techniques, and we will abandon the risky maneuvers. And this is the evolution. But I believe that it's a great advance in rhinoplasty, and I support the people who does the preservation rhinoplasty. But on the other hand, I would like to emphasize that it is not so easy surgery. It needs a lot of skill, and it needs an experience. To me, more complicated, more sophisticated than the structural rhinoplasty. And everybody is not are not skillful as Göksel or Barış, or somebody else who is doing this surgery. They are extremely talented persons, and for a average surgeon, to predict the results, it can be difficult. And if they lose the stability of the bony and cartilaginous framework stability, and that is the most dangerous part. It is not it's a risky surgery. I operated the cases, complications of the preservation rhinoplasty. If there is a collapse of the structure, bony and cartilaginous framework, the solution is to go to RIP, and to make a structural rhinoplasty together with the dorsal augmentation. So reconstruction of the preservation rhinoplasty is more difficult than the structural rhinoplasty complication. That's my opinion.
Yeah, let's go through some of your philosophies in secondary cases, okay? And people asked me that you could speak a little bit about your fractures in crooked nose, all right?
Yeah.
And then we can discuss some difficult cases also with here, because there are almost 500 people watching us. And
Mm-hmm.
also I'm going to show, while you speak your philosophies in secondary rhinoplasty, I'm gonna show one of my favorite instruments, which is Nazim scissor, because since the more than 10 years ago, you taught me how to use that, and I know that many surgeons in the world uses it, and I think it's very interesting, very
So,
different.
so bone scissor, you mean that when the scissor I remove the bone?
No,
You're
the
talking.
the dissection, Nazim dissection scissor, the very fine
Yeah,
tip.
I designed recently a bone scissor. That's very useful tool. Maybe I show you a very short video about that. It's very delicate tip scissors to reduce the bony dorsum, and that's very useful. Uh, anyway, regarding the secondary rhinoplasty, my philosophy, of course, structure. Everybody agrees that in the secondary rhinoplasty, if the essential or the structure part of the nose is over resected or lost the stability or deviated, we have to reconstruct the skeleton, and to reconstruct the septal L strut stable, and achieve a stable L strut. And the reconstructed tip cartilage, and then, if needed, the augmented dorsum on top of that. So it is a challenge. I can say, Fernando, I did a lot of mistakes in the secondary rhinoplasty as well, and I feel more confident, in the recent few years, to maybe 2 3 years, in secondary rhinoplasty. I I made a lot of mistake. What I say, I overgrafted many cases. So, you know, in many of those cases, I use RIP. But to me, the most difficult part is to balance the graft and the soft tissue, to achieve the balance between the soft tissue envelope and the cartilage grafts. In many cases, I put a lot of grafts, a thicker ladder crural grafts, and big spreader grafts, big columnar struts, and ended up with unhappy patients. So again, the principle must be to fix the nose, to reconstruct the nose with the minimal grafting, but
Yeah.
achieve a stable septum and tip framework. So I am uh, much more uh, careful right now, much careful in in uh, in putting grafts, particularly to the tip cartilage, because I ended up with a big tips, and even the external nasal valve collapse in the past due to the volume of the cartilage graft. So, if possible, of course, the principles should be uh, the reconstruction nose with the own tissues, the local tissues, the ailer, not to put any graft, but if needed, of course, we have to do a structure uh, tip, and but instead of putting thicker graft today, particularly in female patients and thin skin patients, I I thin the lateral crural grafts very much, even like 0.3, 0.4 millimeters, like the thickness of the alar cartilage. So this is important because our Bible, our guide should be the normal anatomy, and overgrafting is a big problem in secondary rhinoplasties. But in some cases, we need strong structure. For the septum reconstruction, we can use thicker grafts, stronger grafts, and on the tip, we must be very careful in placement of the grafts, and also thickness of the grafts. And the dorsal augmentation is another challenge, because once the nasal dorsum is resected, the anatomy, normal anatomy, is totally uh, distorted and disrupted. So we we augment the nose with a tissue, with a graft, which is not the original shape of the dorsum, because dorsum is a kind of dome shape, but to give that dome shape with the onlay graft is extremely difficult. So in the past, I used to use the solid onlay grafts from the rib cartilage, and I can say that I revised more than 50% of the solid rib grafts from the dorsum, and due to this edge visibility, due to warping, and there are a lot of complications occurred. And maybe some patients went to somebody else, to the other doctors, to fix it, to correct that. So my complication rate was pretty high. And then I, changed my technique to do dice cartilage fascia graft almost like 15 years ago. And my complication rate was less, but still I had a lot of problems like the irregularities, the step deformities on the sides of the of the graft, and then still I'm trying to improve my results, but I can say that I can get better result with the dice cartilage fascia grafts or only dorsal only fascia grafts. But also at that point, the principle should be also to use a graft as thin as possible. So that's why in those cases, what I do first to the most, depressed part, most scooped part of the dorsum, I put an onlay graft from the septum cartilage if available, or from the soft part of the rib cartilage, and fix it to the depressed part of the dorsum. And on top of that, I put a thinner dice cartilage fascia graft, and if necessary, to the side of the dice cartilage fascia graft, very finely diced pre-dice cartilage grafts to camouflage the edges of the dice cartilage fascia graft. It needs also a learning curve. There is no ideal method for the dorsal augmentation. So so what I can say that
Do you want
one of
to
the yes.
show one of your cases? Maybe people can see in pictures.
Well, also I would like to say one thing. I am dealing with a very very tough cases. I didn't bring
Yeah.
here the most difficult case. I did more difficult cases with the soft tissue problems, skin envelope problems. So the ideal I operate that kind of patients with the skin deformity or skin uh, contracture or the scars or depressions, that kind of problems. They are even more challenge, but again the secondary rhinoplasty to finish the surgery with the graft as minimum as possible instead of big grafting. So the case I'm going to share here,
Yeah. I'm gonna put your, yeah.
I don't know if you can see. Can you see that?
Yeah.
Or do you want me 1 second? Can you see that?
Yes, we can see that. It's perfect.
Okay, this is a very really beautiful lady, uh, 22, 23 years old, came to me from another country. By the way, more than half of my patients are secondary, and more than half of my patients are coming from abroad, usually referred by the colleagues, plastic surgeon colleagues from all over the world, and that kind of difficult cases are coming, and I enjoyed operating them. Of course, these are the most risky cases. This patient has a really, uh, had three previous operations and damaged skin, particularly on the right side of the tip. This is the most scary cases. These are the most scary cases because when we do the dissection, we can compromise the vascularity of the tip. As you can see, particularly on the right side, there's a big depression here, and the skin
Yeah.
is very thin, and the nose is over rotated, over shortened, and the dorsum is, actually not too low, but the tip is too rotated. So in that kind of short noses, I wouldn't like to augment the dorsum much, because that will stretch the skin and it will cause the skin retraction. And when we here you can see better on the
Yeah.
base, the columella was distorted, really damaged the skin of the columella. Here you can see the skin is very damaged. There's a big depression. And I
Yeah.
told the patient that, your case is very difficult. I will do my best to improve your nose, but you know, you do not expect a perfect nose. There will be an improvement if you agree to do surgery with me, and I will be happy to operate. Anyways, she is referred by a surgeon. That's why she accepted. And then I went to the surgery. Can I go to surgical sequences?
Yes, yes, you can go there.
Okay. I opened the nose, and here you see that this was a mess.
Yeah.
Normally, what I learned from Dean Toriumi, if there is a lateral crural remnant, I use it for dome reconstruction, because on the tip reconstruction, the most critical part is the reconstruction of the dome. To the
Yeah.
sides, you can put lateral crural strut grafts. To the middle, for the lower leg of the tripod, you can put columellar strut or septal extension graft. But in cases with but for the dome reconstruction, we need a softer tissue, and it's ideally the best thing is the lateral crural remnants if the domes are totally destroyed. But in this
Yeah.
case, even I couldn't find a remnant to do the dome reconstruction. So what I did to elongate the nose, I put a spreader graft unilaterally. Why I put unilaterally in this case? Because there was not enough room for the two spreaders, and put a caudal septal extension graft and fix it to the spreader graft. For the tip reconstruction, these are the lateral crural grafts which were sutured to the caudal septal extension graft, because these tip cartridges were totally destroyed and was not useful for dome reconstruction. I directly sutured the lateral crural strut graft to the caudal septal extension graft. Caudal septal extension graft is used to elongate the nose. And
Okay.
then here I put perichondrium of the rib. These are prepared from the rib cartilage. So,
Okay.
and to camouflage the dome, and this is two layers of perichondrium. And so the tip tripod is reconstructed. Also here, you see that the
Yeah.
damaged skin, very thin skin. Underneath that, I sutured a perichondrium. This is the perichondrium of the rib cartilage. And you see that this is a very scary surgery. In my life, by the way, in 3 cases, I had skin uh, compromise, vascularity problem. All those cases were the short nose, because when you stretch the skin, you compromise the vascularity of the skin, and this is the one of these cases are really scary for me. To short noses with the scarred skin. Here you see that the
Yeah.
columellar skin was not very healthy, but fortunately healed well. Anyway, the patient came back to me a year later. He said, "Oh, I improved a lot, but I was not happy with the result." So, in this type of patients, I always say very difficult secondaries. I may do a second touch up for you. And then I said, I can do, this is the result after that. And still there is a depression here and on the right side, which although there is some improvement and the result was not super. And I went another surgery. I took a ear cartilage, which is softer. I prepared pockets on the tip with very carefully and with the very delicate scissors. I prepared the pocket to the depressed part. Also, I prepared the pocket from the other side for a shield-shaped grafts, and the perichondrium side was placed to the skin side. So I put a shield graft here and onlay graft here into the after preparing pockets. Then after that, the patient came to me 1 year later, and now the result was better, and she was really happy
Great.
with after the second touch-up procedure. And here you see that from the right side, the columella is the projection is increased, the tip
Yeah.
is derotated, the long nose is elongated. By the way, I didn't put any dorsal graft, very minimal graft to this part, only to this keystone part I put very small onlay graft in this case. And the tip depression was improved a lot, and the nose became longer,
Yeah.
and this is the other quarter view and the base view. Of course, there are still irregularities here, but there is not any other solution, and she was happy anyway, and I don't want to do anything. In this type of cases, one of the biggest mistake, if the patient complains about little depressions, the biggest mistake to do a filler to that part on the tip. You
To do
can
what?
kill the skin to make a pillar to camouflage that irregularities. In such a scarred nose, if you inject a pillar to correct this kind of, the irregularities on the tip, because the skin is already very scarred, and when you inject a pillar with pressure, you can easily compromise or disrupt the vascularity.
No, yes, very nice tip because especially in very tertiary or quaternary cases like this one, right? There is a fibrosis on the skin.
Okay, this is a
Yeah,
case that I would like to present.
sure. That was amazing result, Nazim. Amazing result. Thank you so much.
Uh,
Um,
okay,
I'm gonna show you. I'm gonna show here also because everybody on the last lives they were asking about discussions. So I'm gonna
yes,
show very quickly one of the cases. All right.
yeah. You show your case, and after that, let's go to the discussion and let's receive the questions from the audience.
Yes, perfect. So can you see that?
Yes, I can see.
Yeah. So this is a patient that he had a previous surgery, and we can notice that was um, over resected and a lot of very big retraction on the right side, and also a deviation of the nose. And we can see his profile was not so bad, but except for his strong retraction of his right side, both sides, but worse on the right side. In a closer view, you can see the axis deviation of the nose and a very big retraction on the right side. And I always say that these kind of patients, sometimes you're expecting that it's not so bad, but once you open of course, it's different. So it's like a surprise. Every rhinoplasty is a surprise, right? So I'm
Yes.
gonna go through what I did, and of course what I learned from you, the interview me, and all these concepts together to work in secondary cases, because um, I put all these things together. So first we harvest the perichondrium and also the rib from an incision, the perichondrium, and sometimes the um, abdominal fascia that I learned from you. We do a very small incision, and then when we opened, there was a very bad scar tissue on the tip, and his lower lateral cartilage were kind of destroyed and over resected, and also his caudal septum was distorted and fractured. So what I did was I tried to was so distorted, so I removed the lower part because it was causing the distortion. I did a subtotal septal resection, and then that was after the resection. So it was empty. I had to reconstruct that, and um, just a second here. There's a video. Can you see that?
Yeah, I can see.
Yeah. So after that, just go back here one slide.
You use rectus abdominis fascia.
On this case, I used temporal fascia because I thought it was a little thick. The abdominal
No.
fascia, but yeah,
The- why you go to another donor site? You're already,
yeah,
on the rib side, and in the beginning, many colleagues, many surgeons say that it cannot be, but now they agree that it's very useful, even more useful than the deep temporal fascia, and the survival rate is as good as the deep temporal fascia. So
yeah.
now
Just
every secondary surgeon are using rectus fascia if they harvest the rib when they do dice cartilage fascia grafting.
just a second. Just had a little problem here. Just open it again, and yes, you're right. If you're dealing that, we're already there. It's easier, right? Just open it again. Just a second. Um, yes, now I can open it
Did
again
your
and
video not working?
show the rest of. Yeah, just the keynote just
So
closed.
why,
So I'm gonna open again and show you here.
while you are preparing
So my
to
first
the
option is
audience, I've been using I've been using the rectus
yeah,
abdominis fascia since the 2012, and I used in over 500 cases, and I
okay.
didn't see any problem regarding that, and the survival rate is as good as the deep temporal fascia. The cartilage survival, no problem. Even it's more advantageous in the thin skin patients because it's a thicker fascia. It's ideal for for the DCF. Yes, when you're ready, you can go on.
Okay. Yes, I learned from you to use the abdominal fascia, and every time I'm already there, and I try to use it. In some cases, this is one of the cases. I couldn't harvest it very well, and sometimes I think it's thicker. But yes, I tend to use the same one. Yeah.
I always harvest the seventh rib, which is more straight. It's not curved, and
Okay.
I can prepare longer grafts comparing to sixth rib. In some cases, longer struts are needed. You know, particularly in the short noses, because on those cases we have to put long spreader grafts above the septoethmoid junction, and
Yeah.
to and like maybe sometimes 4 centimeters grafts are needed in some cases. So, so this one advantage. The other advantage is much easier to harvest. You know, to harvest the rib cartilage to me takes, 5 minutes. I'm not exaggerating. You know, the so when you're ready, I'm talking just to,
I'm gonna show here on my iPad, okay? Just because I had a problem here
yeah, okay.
on my computer. So I stopped here. Yeah, I think people can see that, right? And can you see that?
I can see.
Yeah. So first I did the resection, and also the subtotal septal resection.
Mhm.
Okay. And then we did a reconstruction with extended spreader grafts and also a septal extension graft with rib cartilage.
Did you
And
pick
then we
the spreader grafts to the bones or only to the septal remnant?
to the septal remnant. And then we
Right.
did a DCF on the dorsum for to treat irregularities and have some volume there. And also then we did we put it the alar strut grafts, long alar strut grafts, to put on the correct position to reconstruct, but that was not sufficient. So we proceeded with alar articulated ring grafts because he had a very strong retraction. So I did articulated ring grafts on both sides. And even on the also I used fat graft, like I learned from Dimper Yumi, injected in fascia, which I think it's very good in cases like you showed. For when you think that the quality of the skin is not so good, you can use it under the incision to prevent some kind of problems. And also, I use it this fascia with fat graft injected. So this is injecting the fat graft in the fascia, and then I put it on the tip to cover the grafts, and
Mhm.
also to cover the incision, because in secondary cases I'm also afraid of some problems on the incisions. And after that, I still proceeded with an inhaler ring on the right side because it was really retracted. I use a gauge, a 14 or 16 gauge, and I put the graph there. And this is not the same case, okay? But a lot of people asking about some preform aperture problems. So in some cases, we can also resect a part of the bone and also the mucosa. This part here, I resected on the lower part and also resected some bone for breathing problems. And I proceeded with a composite graft sutured on the lower part. And this is the uh, the final result on the operating room. A straighter nose and a better profile. You see that?
Yeah, I see. Awesome.
Yeah. And here on post operation, uh, better aesthetic lines, better symmetry of nasal base, three quarters view and base view, better reading, better airway, better symmetry,
Mhm.
and that's it. Okay.
Congratulations. Very good. Very good.
Oh, thank you. Learn from you and
Yeah.
all the guys and mentors that are always teaching us. Thank you. So Nazim, let's go for some discussions, right? Let's open here for questions. Do you want to say anything else? Because we had already 1 hour and 20 minutes, and I didn't even realize that was we had so and you have another meeting after here, right?
Yeah.
Yes. So let's go for some questions. Yeah. There are so many questions. Thank you for sending, but let's proceed. What they think about the use of diced cartilage glue graft for dorsal augmentation?
Well, I think it's very logical and useful to dice cartilage fibrin glue graft, but it's an additional cost, you know, that can be used. It's as good as the dice cartilage fascia graft, but dice cartilage fascia grafts are should not be put as a sausage.
Yep.
They had to be, fabricated exactly fitting on the defect. So I worked a lot to give the shape to the dice cartilage fascia grafts. So the fibrin glue graft within the syringe, within the 2.5 ml syringe, after cutting the syringe, and we can put into the syringe, to the half of the syringe. How can I express it? And it can be a template for the fibrin glue dice cartilage graft, and without fascia it can be put on the dorsum. So I think it's a good idea, but fibrin glue is an additional cost. I wouldn't like to use, artificial material. Maybe there is no side effect, but I don't want to use the tissue glues. Like
Right.
what is that? Tissue glues. We use the skin closure, uh,
Yeah.
like
And
Japanese glue.
and what do you think? Another question here. What do you think about oblique split method in the rib graft?
Well, I think oblique split method is a good technique for to avoid warping of the rib cartilage. However, when I harvest the seventh rib, I do not harvest the whole rib in 90% of cases because I don't need that much rib cartilage. So maybe here I can show how I harvest a rib cartilage. 1 second. That can be a 1 second. Can you see that?
I'm gonna mirror it for people. Yeah. Now they can see that.
So what I did, I make a parallel incision to the axis of the seventh rib, inframammary fold incision, and I am using here a straight chisel, not not a blade, because this is much less risky comparing the blade, and we go and forward maneuvers and back and forward maneuvers. I harvested here only the lower part of the rib cartilage, not whole rib, because I don't need in many cases that much graft. And this is the 5 millimeters chisel. Look at how straight is that.
Yeah.
And this is the seventh rib, and I can prepare longer cartilage struts from that. And
Okay.
if I need longer spreader grafts, I can prepare from that. With the oblique cut, the maximum length of the graft is about 2.5 centimeters or 3 centimeters. So in many cases, I need longer graft. On the other hand, I don't need straight grafts, exactly straight grafts, except columellar strut or caudoseptal extension graft. The spreader grafts are slightly warped. I can compensate two spreaders with suturing together, because usually we put two spreaders. And I don't mind if my lateral crural graft is slightly convex, which I may even like it better, because to give a more convexity to open the external nasal valve. So only graft I really need it, it really need to be straight is the columellar strut or caudoseptal extension graft between the two
Great.
spreaders. And I select that graft very carefully. And with the seventh rib, usually all my grafts are straight. They do not warp, and
Okay.
I soak them into the saline water before I use, like 15-20 minutes, and I can feel that which graft is gonna warp. And warping is not a problem for me, really.
Okay. And what is another question here? What is your opinion about fat graft? Do you like to use it or do you use it frequently?
For augmentation, no. For
Okay.
camouflaging the irregularities, what you can do, you can prepare a pocket in secondary cases. Usually the skin is very scarred, and on that area to inject the fat is not possible. You have to prepare a pocket for that. And after
Yeah.
that, survival of the fat graft is really, unpredictable. So
Okay.
instead of that, if I have a depression after my surgery, after my secondary surgery, let's say there is a depression somewhere here. What I
Yeah.
do, again, I will go and show something. Maybe here I find it. What I do. So there is a tool which is developed by if I find it. One second. There is a tool developed designed by Wolfgang Gübisch by the Medicon company. I inject free dice cartilage instead of
Okay.
injecting fat. For my minor uh, minor problems in on those cases, I inject uh, free dice cartilage. Not this presentation. I'm trying to find that. What I do, I prepare a pocket to the depressed part
Okay.
with the tip of the 16 gauge needle, and usually I do in my office, and free dice cartilage, and they inject free dice cartilage with a special tool which is designed by Wolfgang Kübisch. I'm trying to find that presentation. I think it's a very very useful,
Yeah.
very
While you look for that, I'm just gonna tell people here we still have we have almost 1 hour and a half, and people will stay there. So thank you so much, everybody. Just a brief thing here. This month, at the end of this month, we're going to do a live on an online live mentoring in rhinoplasty. Okay, so I'm gonna put the link here, and also I'm gonna send on the comments if you wanna save it or go there and subscribe. And we're gonna do a live mentoring on rhinoplasty. Entonces, amigos de Latinoamérica, yo voy a poner un link aquí abajo y también en los comentarios de una mentoría que nosotros vamos a hacer live online este mês, ok? Al final do mês, tá? E obrigado aos amigos do Brasil. Vou colocar aqui o link para a gente fazer uma mentoria live em rinoplastia, tá bom? Vai ser no final do mês. Alright, Nazim, can I mirror your screen again?
Yeah, yes, I couldn't find it, but I would like to, regarding primary, I talked about that. This is the preservation of the vertical fibers of the scroll ligament. I think this is very useful. You see, there is a plane here, and this is the plane that where I reach the nasal dorsum.
Yeah.
And I will show a few slides in 1, 2 to 3 minutes. This is the bone cup removal. What I prefer, majority of my cases, I remove the bony cup with number 15 blade. In many patients, it's very easy. You can think that it's difficult, but this is the lifetime video. You see that I'm cutting the bone. This is the bony cup removal with 15 blade, like cutting the bone, like cutting the cheese. I'm not a bodybuilder. I'm not that strong. Don't.
In your
And
hands,
this is the tool which I mentioned to you, the bone clipper, and show this is for additional for dorsum reduction. I think this is a very nice tool for body reduction. Yeah, it makes a very straight cuts. And this is you can use 1 year, more than 1 year. It's $100, much less costly.
Yeah.
So, and this is the tool I do the transverse oblique osteotomies. And look at this is the oblique osteotomy. I do incomplete osteotomy to perform a green stick fracture. This is a very controlled osteotomy, and I don't use hammer with the power of my hand. And the discussion was, can you do preservation rhinoplasty in this case, dorsal preservation? No, impossible. No. Because you have to narrow the dorsum. In many cases, cartilaginous dorsum has to be refined. So that is one of the reasons that I don't do the preservation much. You have to narrow this part. So this with the spreader flaps and the osteotomies, this is not the case. And look at this slide. I want to show this slide. This is spreader flaps. You can see just like a normal anatomic cartilaginous dorsum. If you know how to do the spreader flaps well, you can really reconstruct the cartilaginous dorsum beautifully, and you don't need to go to the preservation technique. Then it's a very simple method, and with preserving the horizontal portion of the upper laterals, and after performing the spreader flaps, you end up with the very nice dorsal aesthetic lines, which are wider on the keystone area, like this one. Yeah. And also spreader flaps will reconstruct the cartilaginous dorsum and they prevent you from the open roof deformity. And this is very important. Upper lateral cartilage preservation is very important. Also, we can use the advantage of the asymmetry of the spreader upper lateral cartilage in deviated noses while performing the spreader flaps. And we can thin out the upper lateral cartilage with the tip of the blade and make narrower cartilaginous dorsum while performing the spreader flaps. And as in this example, look at this broad cartilaginous dorsum. What I did,
Yeah.
I still didn't resect the upper lateral, just this portion, medial portion of the upper lateral cartilage is thinned out with the tip of the blade and the narrower cartilaginous dorsum is achieved. These are the tricks of the spreader flaps to achieve a natural dorsum. And also, we can combine the spreader flaps with spreader grafts with the spreader flaps in cases who needs the widening of the dorsum. And also, with this method, we can tension the upper lateral cartilage and improve the internal nasal mass. And also for the keystone, I do in many cases to put a keystone graft, drill a hole to the nasal bones, and reconstruct the keystone anatomy. The goal must be to reconstruct the normal anatomy, or we can use another graft, ladder crural remnant, and fix it to the upper ladder cartilage and flip it down and to reconstruct the keystone. There are too many maneuvers like the pre-dice cartilage or cartilage paste to the keystone area. We with the conventional techniques, we can do many things and we can reconstruct everything. Also, in such a case, if the septum cartilage is deformed, and in those cases, we must do the reconstruction. We cannot correct those cases with the preservation technique. Look at the dorsal septum. This this needs a reconstruction with the splitting grafts. These are not
Yeah.
cases to use the classical method. So in summary, I'm gonna go back. In summary, every surgeon, even though you do the preservation, you must know the structure, because
Yeah.
there are cases that cannot be fixed with the preservation. We must
Yeah.
know all the techniques. And when I'm not against to do preservation. I motivate the people to do that, but we have to incorporate this new method,
Yeah.
gradually, not jump on suddenly. And to do that, not not to have the bad complications.
Yeah.
Select appropriate cases in the beginning, then get more experience and start doing more. But still, there are some cases only can be fixed with the structural rhinoplasty.
Yeah, that's it. I think as a nowadays in a condition as a professor that I'm going to a lot of meetings and I have a fellow, I think the first thing is learn a good structure rhinoplasty and understand all the anatomy and everything. And the preservation thing is something that is gonna incorporate something more in the knowledge base. But I think for a learning process, the structure
Mhm.
rhinoplasty has to come first, of course, and you have to be very strong on that, and then you start going for preservation things. I think I agree with you. Yeah. And Nazim, we're here for almost everybody stayed here for all this time. We have almost 2 hours talking. Was very, very nice, Nazim. I know that many questions are here, but Nazim has another um, thing to do in half an hour.
Yeah.
So I would like to thank you again, Nazim, for everything. Okay, personally, I'd like to thank you. For everything you taught me through all these years since the first time I went to Istanbul more than 10 years ago, and for all your support for any situation that I needed. And thank in the name of everybody who is here because you we took your time and you showed your experience, your philosophies, your thoughts, and these are kind of things that we cannot do in the meetings because in the meetings you have just a little time to speak about your technique, and we don't have this time to talk with you about another things that here we have this time. Okay, so I'd like to thank you so much, Nazim.
Okay,
I
I would like to say a few words before you close. And,
okay,
you know, I have too many friends from Brazil. I love Brazil, by the way. And,
okay,
I have too many fellows, and they became successful, prominent surgeons in Brazil, like Tiago, like Carlos Rocho Jr., like
yeah,
yourself, like Bianca Ohana. And, then it's a really, I'm proud of all of you. And we planned an ISEPS rhinoplasty attached to your national meeting in
yeah,
October one day. I hope we will be able to do that if this corona virus situation, will be better and we will be able to travel. And I came many times to Brazil, and I love Brazilian colleagues. And my best friend is Brazilian, Dr. Sals. And
yeah,
also to the members, to the audience, I really encourage them to be member of ISEPS. And as you know, I will take over the ISEPS presidency in September. And Brazil is our biggest partner, and in terms of membership, the second largest country. And so I came to Brazil maybe 8, 9 times, and I would love to come back during my presidential term. I hope my first visit will be to Brazil. Also,
sure,
if you are not member of ISEPS, please become member of ISEPS. We have a lot of member benefits, and in terms of education. Also, now I'm going to attend to Rhinoplasty Society of Europe webinar in 15 minutes.
okay,
So you can be member of Rhinoplasty Society of Europe. Current president is Dr. Enrico Robotti, who is one of the best nose surgeons in the world. Also a wonderful guy, very nice person. And the Rhinoplasty Society of Europe will also teach you a lot in rhinoplasty. Thank you so much, Fernando. My greetings, all my friends in Brazil, and so hope to see you soon.
thank you, Nazim. As you said, in November, if nothing changes, we have the Brazilian meeting, and Nazim and Goxiel are going to be here. We're organizing a rhinoplasty session, like a pre-congress, so
Yeah.
everybody are invited. We still have some places to for invitations. We're trying to invite some more people, and we're gonna update everybody. Okay, thank you
Yes.
so much.
Okay. It was pleasure to be with you. Thank you for organizing such a lovely, nice live webinar. Bye
Oh,
bye.
thank you. Bye bye, Nazim. Bye
Bye
bye.
bye.
All right. And for people who are still here, next live, we're doing every Saturday. I think this is been very exciting. Thank you all, because I never thought it would reach that kind of proportion with so many people coming and watching from the beginning to the end. Thank you so much. So our next live is on Thursday. All right. I will tell you guys during the week who is, but I know that many people want to see this guy, because many people have a lot of doubts in selection patients for preservation, because here in Latin America, in Brazil, we have a lot of thick skin patients. So we're going to talk about that on next Thursday, 23rd Thursday. I'm going to update you through our social media. All right. Thank you so much, everybody. See you this week during our live, or see you on Thursday during our live talk with our guests. All right. Bye bye. Thank you so much.